All right, if everybody wants to take a seat, I think we'll be just about ready to get started. Let me just scoot that because I'm going to probably knock it over. It's a poor way to start. All right, so welcome everybody to our weekly orthopedic surgery grand rounds today. I have the honor of introducing Dr. Alejandro Casalino. So Kaz is one of our current fourth-year residents. He's originally from New York, went to Columbia for undergrad where he studied psychology and neuroscience, and then did medical school at University of Pennsylvania. And while he was there, I think had a pretty interesting path. He was involved in a few startups. He was the director of research for a company, worked at a cervical spine implant company, and had a few other endeavors outside of also excelling as a medical student. And he was quite productive with research, and then we were fortunate to have him matched with us here at UCSF. While here at UCSF, he's really continued on this great path. He's been awarded the OREF Resident Research Grant, which we'll hear a lot about today. He's had numerous other awards, a lot of publications in pediatrics, arthroplasty, kind of all across the board. And then he is now matched at Stanford. He'll be doing adult reconstruction, so joint arthroplasty after he finishes his chief year with us. I think Kaz, I think we all know him to be very thoughtful, very, I think, introspective and great at taking care of people, communicating. And he will be talking to us today about patient expectations, outcomes, and satisfaction. So Kaz, thank you for doing this and look forward to your talk.
Thank you so much. Hey, everybody. Thank you for this opportunity to present today. I'll start by talking about patient expectations, outcomes, and satisfaction, and then I'll tell you a little bit about our experience developing a preoperative patient expectations tool. I have nothing to disclose, although this work was funded by both OREF and SRS. So today I'll be talking about patient expectations. I'll start off by explaining a little bit about what I mean when I say patient expectations by giving a few examples. Then I'm going to discuss and provide a short explanation of why I think that this is an important topic to discuss and understand. I'll then go into a bit of the background on the origins of patient expectations and the theories behind them. From there, I'll contextualize patient expectations within the orthopedic literature. Then I'll move into our own work on developing a patient expectations survey. Finally, I'll leave you with a few things that I've been thinking about as I've been putting together this talk. I'll start by describing what I mean when I say the phrase patient expectations. Throughout this talk, I'm specifically going to be talking about preoperative patient expectations. Expectations have been looked at within the context of medicine for several decades. Only recently have they been rigorously studied and evaluated as we move away from physicians being the sole determiners of a successful treatment. Expectations vary from person to person based on their life experiences. In the context of orthopedics, patients may have various expectations of their surgery, including the resolution of their pain, improvement in their function, a return to activities, a return to their baseline, improvements in their appearance, and various psychological benefits, which are all expectations that have been elucidated from patient interviews. Depending on the indication and the surgery, some expectations may be realistic, while others might not be. Integral to these expectations are the conversations and relationships between patients and their doctors. So now that we've seen a few examples of patient expectations, let's talk about why they matter. Within the orthopedic literature, it has been shown that patients with higher preoperative expectations have better outcomes. We have also found that patients that have their expectations met have higher satisfaction. I'll talk more specifically about the literature shortly, and I'll also provide some theories to help explain this finding, which at first glance may seem surprising. We as doctors have the ability to change expectations by talking to our patients. But if we don't ask or try to understand their expectations, then a disconnect can grow between what the surgeon and patient expects. This disconnect can lead to poor outcomes, dissatisfaction, and in the most severe cases, lawsuits. I think that the last question on this slide is the core reason to study expectations. If expectations are related to outcomes and satisfaction, is there a way for us to modify expectations to improve these measures without even needing to make any changes in the OR? I personally went into orthopedics because I wanted the ability to have a tool at my disposal to make people happy and bring them joy. Because selfishly, I like when people like me. So my interest in expectations truly stems from this hope and desire to improve satisfaction, which is in my mind a proxy for happiness and joy. So now that we know the what and the why, I'll go over the background of expectations. I mentioned earlier that higher preoperative expectations have been associated with improved outcomes following orthopedic procedures. I'll now discuss some of the theories to help make sense of these findings. Even centuries ago, doctors were aware that the expectations that patients had prior to undergoing treatment would affect their care. Placebo effect, as we know it, was first described in the 18th century. This quote, "Cure occasionally, relieve often, console always," was said by Ambroise Paré, a barber surgeon to the French royalty in the 16th century, and it demonstrates that even back then, doctors knew the importance of providing consolation to their patients. Treatments were prescribed that had no known medicinal properties, but these medicines helped to soothe the patient and to provide reassurance that something was being done. The interaction between the doctor and the patient was the treatment. Although we've come a long way from solely providing reassurance, how we talk to patients and setting expectations has a large effect on the perceived success of treatment. Using the phrase placebo carries a negative connotation, but it cannot be ignored as having a meaningful and clinically significant effect on patients. Recently, there have been several Cochrane reviews that call into question the validity of the placebo effect, because many of these studies did not compare to no treatment. However, these meta-analyses did demonstrate persistent effects for treatment of pain, which is specifically important to us as orthopedic surgeons, given most of our indications are related to pain. It has been hypothesized that patient expectations can alter outcome through mechanisms similar to classical conditioning. My psychiatrist mother is very proud that I'm bringing psychological theories into my orthopedics grand rounds. As many of you know, the classical conditioning is the linking of a stimulus and response, which was initially described by Pavlov and his dogs. But I think my favorite example is from The Office, when Jim trains Dwight to expect an Altoid whenever he makes his computer chime. This relationship has been shown to hold true in the medical field as well. Patients who have been conditioned to expect an adverse effect to a medication have that effect despite taking a placebo. Similarly, patients who were told that they were taking a hallucinogenic drug experience hallucinations despite taking a placebo. This theory helps explain how an expectation can cause a physiologic response in patients. There have been several models to attempt to explain the relationship between expectations and their impact on outcomes and satisfaction. Flood and colleagues helped to summarize the 5 mechanisms that link expectations to outcomes. They describe how expectations can trigger a physiologic response, as I described previously through classical conditioning. Expectations are also seen as motivators for patients to themselves achieve better outcomes. Patient expectations also condition them to observe certain symptoms while ignoring others. Having expectations can also change a patient's understanding of their disease process. Finally, expectations can act in concert with anxiety to either heighten or reduce certain symptoms. As we saw from the mechanisms underlying the relationship between expectations and outcomes, The connection between the mind and the body cannot be ignored. The phrase, "it's all in your head," may be more true than we previously gave it credit. There have been several studies that have provided pathways to explain how mood and affect can alter disease progression through both behavioral as well as non-behavioral pathways. Studies into psychoneuroimmunology and psychoneuroendocrinology have provided evidence for how negative affect states and the experiences that cause them, for example, a slower or less complete recovery than expected, can lead to pathogenetic alterations through mediators of the immune and endocrine system, i.e. pro-inflammatory cytokines, cortisol, and other mediators that are known to have effects on the musculoskeletal system. Now that we understand the pathway through which expectations may alter patient outcomes, we can start to look into how to study these expectations. Although the importance of expectations has been described in published literature since the 80s, a validated tool to measure patient expectations in the orthopedic literature did not come around until the early 2000s. Carol Mancuso is truly the matriarch of orthopedic expectations literature. She works at HSS and is a collaborator in the truest sense of the word. She gathers teams of surgeons around her to develop these surveys within the various orthopedic subspecialties. She was the first to develop a validated survey within the expectation space in orthopedics, and her surveys are now the gold standard for measuring patient expectations. When we were working on our survey, I was lucky enough to have a Zoom meeting with her to discuss about how we should move forward with developing our own project. This was her first article, Patient Expectations of Knee Surgery, which described a method for creating a validated patient expectations tool. The article looked at a wide variety of pathologies, all of which pertain to the knee. There are several factors that undermine the importance of this paper, which include the fact that this survey responses were patient-derived. Additionally, this paper provided a framework for future work in the expectation space by laying out the exact methodology required to replicate similar surveys. And finally, this was a validated tool, meaning that it was put through rigorous statistical processes in order to ensure the validity of the reported results. In the era of patient-reported outcomes, it's easy to forget the paternalistic nature of medicine and how we previously evaluated success. Prior to patient-reported outcomes, we relied on physicians judging whether a surgery was successful based on various clinical outcomes, including imaging, clinical information, complication rates, and physicians' perceived outcomes. PROMISE, the NIH-funded program to measure patient-reported outcomes, was founded in 2004. So the fact that this paper in 2001 was already working towards patient-derived responses demonstrates the foundational nature of this work. These survey responses were generated through performing structured interviews that allowed patients to provide their responses. Patients were provided open-ended questions and were able to give what they thought. The questions included, what are your expectations of the surgery you are going to have on your knee, and how important is each expectation? Therefore, the survey is patient rather than physician-derived, as opposed to previous surveys that had utilized a list of expectations that the investigators had deemed would be important to the patient. These interviews were then analyzed, utilizing qualitative research techniques in order to generate the surveys. I'll go into more detail about this process when I discuss our work developing an expectation survey, but all of our techniques were based off of this first paper. The paper resulted in 2 separate surveys, one for patients who are undergoing a wide variety of knee surgeries, including surgery for pathologies involving the ACL, PCL, MCL, LCL, meniscus, chondromalacia, as well as OA debridement procedures. The second survey was for TKA. As you can see, the TKA survey is 17 questions long, and the knee surgery one is 20 questions long. Some of the expectations included for the surveys included pain relief, improved ability to walk, improved function of the knee, return to certain activities, improved ability to interact with others, and improved psychological well-being. Some of the differences between these two surveys include that patients were potentially expecting to return to professional sport after their knee surgery, while that was not an expectation of the TKA patients. Additionally, the expectations that the knee would be back to the way it was before the problem started was not an expectation held by the TKA patients. These surveys were validated by various measures and take less than 5 minutes to complete. In addition to this study's long-term implications on the expectations literature, this study had several immediate benefits. This survey provided surgeons with a tool that they could utilize to guide conversations with patients. The survey responses are able to condense possibly long and vague conversations down to a list of specific statements that the patients expect. It also allows surgeons to address both realistic and non-realistic goals. For example, an expectation that a patient will be able to return to all pre-injury activities following surgery may not be a realistic goal. Finally, the survey provides a method to guide a conversation with patients who may be dissatisfied following surgery and can be used to remind patients of what was discussed preoperatively as realistic expectations. Following the creation of the knee surveys, Mancuso and her collaborators began working on surgical procedures and other surgical subspecialties. This was the next preoperative expectations survey that she created, which focused on total hip arthroplasty. She utilized similar techniques as described for the knee survey in order to create this one. In this survey, they also obtained patient-reported preoperative function measures, including the AAOS hip and knee modules and the SF-36, and found that patients who had worse preoperative function had more expectations and felt that those expectations were more important. She continued working through subspecialties and indications, moving next to shoulder surgeries. This was a 17-item survey for indications including impingement, OA, instability, rotator cuff tears, and adhesive capsulitis, which is similar to the previously described knee survey. She also created surveys for patients undergoing cervical and then lumbar spine procedures, again, not for a particular indication, but broadly looking at patients undergoing surgeries in this region of the body. She continued to make her rounds on the orthopedic subspecialties, next moving on to foot and ankle, and then also began to become more specific in the surveys, creating surveys for specific procedures. At this point, the process for creating these types of surveys was well described, which allowed others to follow her methods to create similar, validated preoperative patient expectation surveys. This study was also created at HSS, which utilizes all of the techniques that Mancuso had created, but also takes them one step further. One of the main differences between the study and the previous studies is that it is looking at one surgery being performed for one indication, although surgical reconstruction techniques did vary amongst the patients. Additionally, this survey was shorter than the previous surveys because longer surveys can be cumbersome to patients, and anyone who has done work collecting surveys from patients knows it's really hard to get them to fill those surveys out. So any barrier that can be lowered, such as shortening the survey, should be done. Also, rather than having the surgeon select the items on the final document, they asked patients to rate the importance of the various responses and selected the 10 most frequently cited responses for their final survey, further reinforcing the patient-centered nature of these surveys. When we were developing the methods for our preoperative patient expectation survey, we based our methods on this paper. There are many more tools available now for the various subspecialties and for specific procedures, but for the sake of time, I'm going to move on to the next portion of the talk. We now have these tools to measure preoperative expectations, but how do these expectations relate to outcomes? The most robust literature centers around arthroplasty. I'll also present literature regarding shoulder and spine procedures, although there is other literature regarding all the other subspecialties as well. Several studies have looked into patients' preoperative expectations, and the majority have found that a greater number of preoperative expectations or a higher importance tied to these expectations are correlated with improved outcomes following surgery, which can be explained by many of the factors I discussed earlier in the background portion of my talk. At 6 months, TKA patients with more expectations had greater functional improvement. THA and TKA patients with greater expectations of pain relief and higher SF36 and pain relief had higher SF36 and pain relief at 6 months, and this improved pain relief persisted at the 1-year time point. Patients at 1 year after THA who had a higher number of preoperative expectations had a greater decrease in their WOMAC scores. To give the full picture, there is some literature that demonstrates that greater expectations are associated with poorer outcomes. As shown here with the THA patients at 3 months with higher expectations having decreased pain relief. However, the majority of the literature points towards a positive correlation between expectations and outcome. A similar correlation has been found in the shoulder literature, linking higher preoperative expectations with improved patient outcomes. These relationships have been all found utilizing the HSS shoulder survey that Dr. Mancuso and her colleagues had developed. For patients undergoing rotator cuff repairs, increased expectations were found to improve performance on the simple shoulder test, improve SF36 and constant Murley scores, decrease VAS pain, increase VAS function, and increase VAS quality of life scores. For patients undergoing total shoulder arthroplasty, increased expectations were correlated with increased ASES and SF36 scores, as well as decreased VAS pain scores. Finally, for reverse total shoulder, patients who had a greater expectation of nighttime pain relief had greater improvements in their ASES and VAS pain scores, while patients with greater expectations of participation in non-overhead sports had greater improvement in their shoulder activity scores. In the spine literature, the same correlations have been demonstrated. Patients undergoing a wide variety of lumbar procedures who had higher expectations were found to have greater improvements in their SF36 physical scores. Patients undergoing both lumbar and cervical procedures with increased expectations were found to have greater functional outcomes. Finally, patients undergoing surgery for lumbar spinal stenosis with greater preoperative expectations were also found to have improved functional outcomes. Although I will not touch on them here, similar correlations have been found in other orthopedic subspecialties, as well as in other surgical fields, including general surgery, ophthalmology, and cardiothoracic surgery. These correlations have also been shown in non-surgical specialties as well. Now that we understand how expectations relate to outcomes, we can start looking into how expectations relate to satisfaction. Even though outcomes are important to patients, satisfaction is in some ways even more important, given that patients with good outcomes may be dissatisfied depending on what their preoperative expectations of surgery may have been. At its root, the idea of satisfaction gets at if a patient was offered the surgery again, would they pursue it? That being said, there is minimal high-quality literature linking expectations to satisfaction. Part of this issue is that satisfaction is a multidimensional, complex idea to quantify. Satisfaction means different things to different people and can even mean different things to the same person at different times in their life. Therefore, creating a tool to measure it has been somewhat elusive, despite many efforts to try to quantify it. In orthopedics, this tool has often been distilled down to a one-question survey. Are you satisfied? Which at this point, I hope I have impressed upon you is not enough. Another subtlety that has been oversimplified has been specifying the type of satisfaction. For example, satisfaction with the outcome of care versus satisfaction with the process of care. Patients may be satisfied with the outcome of their surgery, but they may be dissatisfied with the process of their care if it was expensive, difficult to navigate, or put a large burden on them or their family, only further reinforcing the need for better tools for satisfaction evaluation. In the arthroplasty, spine, and shoulder literature, it has been consistently found that meeting preoperative patient expectations leads to greater satisfaction. However, unlike the outcomes literature, having greater or more expectations has been found to either increase or decrease satisfaction, depending on the study. Clearly, we still need to do more work to better understand satisfaction and how to measure it. So far, we've talked about what patient expectations are, why they matter, the foundational literature, and how expectations correlate with outcomes and satisfaction. We'll now move on to how we might modify these expectations. As I mentioned briefly earlier in my talk, part of the importance of developing these tools to evaluate patients' preoperative expectations is because it allows us to better understand what they are hoping for from surgery. I have also shown that patients with greater expectations have improved outcomes. So, if we can modify these expectations, could we potentially improve patient outcomes? Dr. Mancuso and her group began to look into this question. In this study, they conducted 2 randomized controlled trials, one for patients undergoing TKA and one for patients undergoing THA. For each trial, their control group was a standard pre-op class that is provided to all patients who are undergoing total joint arthroplasty. For their intervention group, they had patients attend the standard class, but also provided a module regarding expectations of recovery for the first 12 months after surgery. They found that in the TKA group, attending the module on expectations actually decreased the total number of expectations that the patients had, while in the THA trial, attending the module increased the number of expectations. Unfortunately, they did not correlate these expectations with outcomes, nor did they correlate them with satisfaction. But by altering these expectations, they may have allowed patients to meet more of their preoperative expectations and therefore improve satisfaction. But again, this study wasn't necessarily looking at that. There's only one slide you're going to pay attention to in this talk. I would make it this one. This study addresses if the modification of patient expectations can improve satisfaction. Similar to the previous study, this group out of the Netherlands divided patients undergoing TKA into 2 groups. They gave one group their standard pre-op class, and they provided the intervention group with a standard class plus a module on realistic expectations following surgery. This module was a 30-minute session, which included 15 minutes of a lecture and 15 minutes of discussion to address general treatment results for primary TKA, as well as patient-specific factors that affect the results of TKA. To measure expectations, they utilized Dr. Mancuso's TKA survey that I presented earlier. They found that the intervention group had a greater percentage of patients who were very satisfied. Nearly 75% of the patients in the intervention group were very satisfied, compared to roughly 50% in the control group. Additionally, they found that overall, patients had a decreased number of expectations compared to the control group, and a greater percentage of patients had their expectations met compared to the controls. Interestingly, they found that there was no difference in patient-reported outcome scores between the 2 groups. Imagine if we were able to increase satisfaction in our patients by 33% without making a single change to our surgical techniques or what we're doing in the OR, and by simply providing patients with a 30-minute class about the surgery they're about to undergo. This is the type of work that really motivates me to continue working in expectations, because there's such impactful change that can be had. Now that we have a bit of context about the current literature regarding expectations in orthopedics, next I'll start to talk about our own experience developing an expectation survey of our own. We decided to focus on posterior spinal fusion for adolescent idiopathic scoliosis. We wanted to look into one procedure for one indication, given this would allow us to create a more concise survey, which is where the field is moving, as demonstrated by the ACL reconstruction survey. This is the first expectation survey created specifically for the pediatric population. Part of the reason we selected the procedure was because, as the name implies, it's performed during adolescence. We thought that if we had selected a procedure for a younger population, we thought that it would be difficult to garner anything meaningful from the patients. Additionally, working in the pediatric population, you're dealing not only with the expectations of the patient, but also the expectations of the family. And we wanted to understand whether these expectations differed between these two groups. Finally, we wanted to look at this procedure because through our experience in the clinic, we found that it seemed that there were certain aspects of patient expectations that we were missing or may not have always been fully addressed. We all know the indications for PSF for AIS, a Cobb angle over 50, and a patient with growth remaining. We performed the surgery in order to prevent cardiopulmonary compromise, as well as to possibly prevent back pain in adulthood. But something that we may not routinely be discussing with patients, but maybe something that they are thinking about, is their appearance. In studies that evaluate this variable, it has been universally found that patients have a disturbance in body image pertaining to their scoliosis. Specifically, scoliosis has been associated with dissatisfaction with appearance, and patients report having a feeling that they are developing abnormally during a time when body image and social stressors are already front of mind. These findings were shown in both genders. Specific aspects that patients reported including feeling unattractive, feeling self-conscious, feelings of lacking physical health as well as strength, and difficulty with clothing purchases, especially during the brace wear period. Although these are clearly things that our patients are thinking about, in my experience, we as orthopedic surgeons are not always keen on discussing these topics, which only further reinforces the need to better understand what our patients are expecting as a result of this big elective surgery we are about to perform on their spine. As you can see from this image, there are several of the exam features that we document in our notes, and these are things that patients note as well. In particular, things that are often brought up include uneven shoulders, uneven hips, and prominent rib humps. So, overall, our hypothesis is our preoperative patient expectations related to patient clinical, demographic, and patient-reported outcomes for patients undergoing PSF for AIS. Given the literature review I just provided, we were optimistic that our hypothesis would be found to be true. Related to our hypothesis, our aims are outlined here. Essentially, we wanted to create a validated survey to measure expectations in patients with AIS who are undergoing PSF. We then wanted to determine if there were patient factors, either demographic or clinical, that were associated with preoperative expectations. And then finally, we wanted to use these expectations that we were measuring and determine if there was a relationship between them and postoperative outcomes and satisfaction. We decided to utilize the methods described by Dr. Mancuso and her colleagues and broke the survey creation down into 3 phases. We also decided that we would create 2 surveys, one for patients and one for their parents or guardians, given we thought the expectations of these survey groups may be different. In terms of determining our sample size, we based this off of previous work. The knee survey had over 100 patients, but this was because the survey included multiple indications and multiple surgical procedures. More recent literature focusing on one procedure for one indication had a more limited number of participants, on the order of 15 to 20. or they recruited patients until they elicited no new expectations. Our inclusion criteria were patients who were 18 years or younger, spoke English, and who were specifically undergoing PSF for AIS. We excluded patients who were older than 18 to keep this a strictly pediatric survey. We also only wanted to look at patients undergoing PSF for AIS and did not want to include other patients undergoing other procedures such as tether, given we felt that these patients may have a different set of expectations. In terms of language, we only included English speakers, unfortunately. One of the limitations of the published expectation surveys is that they are only validated for English speakers. One of our goals is to get the survey translated to other languages and to validate them within these languages. Given the diversity of our patient population here in San Francisco, we had to exclude a large number of patients because either they or their parents did not speak English. This is a recurring trend in the orthopedics literature, where patients who are non-English speaking are not appropriately represented. These patients also deserve to be included in this type of work. Patients from different backgrounds have different understandings, interpretations, and expectations of their disease and treatments. These differences do not just stem from a lack of understanding, but rather are rooted in deeper cultural variations regarding the perception of pain, medications, and surgery. Therefore, looking deeper into the expectations of a culturally diverse population of patients would only further help to address disparities in care. We decided to pursue funding for this project to help with some of the legwork that would be required to complete the project. In discussions with Dr. Mancuso, she recommended utilizing a qualitative researcher to help identify themes and to generate the survey. We also would need help from a statistician and a research coordinator to help with contacting, interviewing, and overall implementation of the study. We were fortunate enough to be awarded my ORAF research grant to help with the survey creation portion. And then Dr. Swarup was awarded the SRS New Investigator Research Grant to utilize the survey to gather preoperative patient data and then collect long-term postoperative data to achieve our goals of studying the relationship between expectations, outcomes, and satisfaction. I do not think I was prepared for how awkward it would be to cold call patients and their families and start to ask them what their expectations were of surgery. For these interviews, we utilized the same format that had previously been described, where we would ask the questions, what do you expect as a result of your spine surgery? And after you have recuperated from surgery, what do you expect to be different? These were structured interviews because we would always ask the same questions, but the responses were open-ended. We would often start by interviewing the parents because the patients were often shy, and then we would move on to the patients themselves. We recorded all of these conversations, and let me tell you, the awkwardness of performing the interviews was quickly overshadowed by listening to myself perform these interviews. We then utilized a UCSF HIPAA-compliant transcription service called Rev to transcribe all of these conversations. The next step was finding a qualitative researcher who would be able to help me turn these conversation transcripts into themes and questions that we could use in our survey. Here's a little bit of background about qualitative research, since I was not familiar with it prior to working on this project. Essentially, qualitative research involves collecting and analyzing data that is non-numeric to better understand concepts, opinions, or experiences. Let's just say most of orthopedic research is not qualitative. I was lucky enough to work with Simon Utram, who is a qualitative researcher here in the Department of Bioethics at UCSF. He helped with coding the interviews, identifying themes within the interviews, utilizing these themes to generate survey items, and then finally helping to create the final draft survey. Our research coordinator during this time, Toshali Katyal, had a background in qualitative research, which was also incredibly helpful. She also helped me conduct several of the interviews. I was thankful that I had Simon and Toshali for this portion of the project, given I did not have the skills to get this part done. Here is the survey we ended up creating based off the patient interviews. We selected the 10 most frequently cited themes in creating the survey. We wanted it to only be 10 questions long to decrease the burden on patients and their families. As we went through the process of creating the survey and conducting the interviews, we noticed that patients and their families had very similar expectations. So the surveys we created for the patients and their parents were actually the same. Despite the fact that they are the same survey, we think it is important to provide 2 separate surveys because it allows us to see which of these expectations are more or less important to the patients versus their guardians. As you can see in the survey, there are several overall themes related to appearance, pain, function, and recovery. The 10 items that were selected include: I expect a straighter spine. I expect to be pain-free. I expect to avoid medical treatments in the future related to my spine. I expect to be able to fully participate in sports or physical activities without pain or restriction. I expect to be more confident in my appearance. I expect my posture to be overall improved. I expect to be able to sit longer without pain. I expect to be able to stand longer without pain. I expect to have a full recovery without any mobility or appearance issues after surgery. Each survey response is graded on a scale of 1 to 5, with 5 being an expectation that the patient or their guardian fully expects, down to a 1, which means that they do not expect this at all. We also left the option for NA, in case the patient did not feel that this expectation pertained to them at all. This allows us to score the survey from 0 to 50, with 0 being none of these expectations pertain, up to a maximum score of 50. We're now currently in this phase of the study. We are still validating the survey, which involves recruiting a whole new cohort of patients, which takes time. Although I've touched on this before, the key to these expectation surveys is their validation. Over 47 different expectation tools have been identified in the orthopedic literature, but the key to expectation surveys that are utilized by the non-originating author is validation. After completing a draft of what we performed, completing the draft of the survey, we performed the Fleisch-Kincaid grade level analysis, which looks at the length of words, length of sentences, and sentence structure in order to assign a reading level that pertains to a certain grade level. We found that our survey was at the 6th to 7th grade reading level, which we deemed as appropriate for the age of our patients, as well as for the parents or guardians who may not have completed schooling. We are currently evaluating the floor and ceiling effects, as well as the test-retest reliability. The floor and ceiling effects helps us ensure that everyone taking the survey doesn't give either the highest possible or lowest possible scores. The test-retest reliability allows us to make sure that patients' given answers are the same despite taking them at different time points. We're also collecting preoperative demographic, clinical, and patient-reported outcomes during this phase, which we're hoping to utilize in our final analysis as long as the survey is found to be valid. I mentioned that we are starting to collect information about patients during this phase as well. Specifically, we are collecting their responses to the surveys, various patient demographics, various clinical measures, and patient-reported outcomes. We've included the SRS-22, the Scoliosis Appearance Questionnaire, as well as various PROMIS modules. For this portion, we are identifying patients in the preoperative period and either meeting them in clinic and providing them with the REDCap survey on an iPad while they are waiting for their appointment, or we're sending them the REDCap survey via email after we've discussed it with them over the phone. For the test-retest reliability, we have been sending patients and their parents the REDCap survey to redo after 3 days from taking the initial survey. Once we finish validation, we'll be able to focus on collecting expectations and patient-reported measures preoperatively, and then following these patients in the postoperative period. We're planning to collect PROs at 6 months, 1 year, and 2 years, so that we can relate these PROs to the patient's preoperative expectations. We also hope to evaluate patient satisfaction starting at the 1 year time point, given this will give time for the patients to have fully recovered from surgery. Although collecting and analyzing the data from our work thus far is critical, because it ensures that we have an understanding of this indication and this surgery. In the future, I think the key will be to study how we can modify variables in order to improve outcomes and satisfaction. As I've outlined here, I think that there are several areas that would be interesting to delve further into. The first one is the identification of certain factors or demographics that may help us identify patients who have more or less expectations so that we can know who to target in clinic preoperatively for more detailed conversations. Next, as was done in the TKA study out of the Netherlands, looking into modifying preoperative expectations and how we can improve outcomes and satisfaction. I believe that without the foundational work we are starting with here, we cannot move on to this phase. But I do think that this is the most impactful type of work and the reason I'm most excited about expectations. Finally, I think that we need to think about how we are talking to our patients preoperatively, especially for elective procedures. In the 2 studies I presented where they were attempting to modify expectations, they discussed preoperative classes that their patients attend and modules that were used as the intervention. I think we need to spend more time on this aspect and figure out how to optimize these types of classes. We as the surgeons do not need to be the ones leading these classes, but I do think that we need to be involved in the development of the curriculum. Since at least from the one study I showed, they can have an incredibly large impact on our patients and how they perceive the results of their surgery. The ability to make 33% more of our patients highly satisfied simply by putting together a presentation about what they should expect from surgery seems like too easy of an opportunity to pass up. So that's where we are with the project. I just wanted to leave you with a couple of final thoughts before I finish up. Starting July 1st, 2024, CMS is going to start requiring that PROs be collected for all inpatient Medicare patients 65 or older who are undergoing primary elective TKA or THA. If hospitals fail to collect these data and report it to CMS, there will be a financial penalty. Starting in 2027, CMS will start to report the PRO data, which will effectively rank hospital systems based on their ability to achieve minimally clinically significant benefit thresholds on PROs. As I have shown, it has been demonstrated that patients with higher preoperative expectations have improved outcomes. Although there is no data yet on the modification of patient expectations and the effect on outcomes, it is possible that this type of work may be able to affect how hospitals are rated and being reimbursed in this new system. This leaves us in a bit of a strange situation. Should we be trying to increase expectations, given it has been demonstrated that increased expectations leads to improved outcomes? Or should we be trying to decrease expectations in order to increase satisfaction, given we found that meeting more expectations postoperatively leads to higher satisfaction? In my opinion, I think that patient satisfaction matters more, but I think there is more room for debate or space for both, and obviously this is an oversimplification of the picture. I want to leave you with one final thought before I finish. Robert McNamara was the U.S. Secretary of Defense during the Vietnam War. He was incredibly focused on data. He strongly believed that in war, if your army could inflict higher casualties and your army sustained fewer casualties, then you would win the war. He was not interested in things he could not measure, and therefore was unable to appreciate the importance of public opinion and other more qualitative measures. Therefore, the McNamara fallacy refers to our tendency to focus on the most quantifiable measures, even if doing so leads us away from our actual goals. Put simply, we try to measure what we value, but end up valuing what we measure. I'm not sure that we're at this point yet in orthopedics, but I do think that we need to reflect and decide what's important for our patients. Here are my references.
Thank you, Kaz. That was great and very thoughtful and I think thought-provoking. I think we have a few minutes for questions. See Dr. Westrak's hand. And
that was really, really great. And congratulations on all your hard work. I had no idea how hard it is to create a tool like that. So keep up the good work, and thank you for a great grand rounds. I would, just like you said, it's so interesting. The higher your expectations, the better you do. The lower your expectations, the happier you are when you meet them. Did any of those studies look at the patient's expectation of the work they would have to do to reach that expected outcome? So I was thinking about the total knees. It seems like that's a tough operation. You've got to work on range of motion. You kind of have to do the work to get to where you're going. So did they measure that yes, I expect to do X, Y, and Z, and I know I will have to do PT? Was that ever measured?
So that wasn't anything that I came across in the literature that I was reading, although it may exist out there. But that being said, I do think that what you're bringing up is sort of how the mechanisms behind how these increased expectations improves the outcomes. So by the patients themselves being vested and having an expectation that they're going to do well, it really motivates themselves to do better. I'm going to work harder in PT. I'm going to take more steps. I'm going to try to take less pain medicine. I think I'm going to do better, and therefore I will do better. This sort of mind over matter that can help explain some of these findings. But again, I didn't find anything that specifically discussed that.
Let's see, Fabian.
Thank you, Kaz, for this wonderful talk. I think there's a lot of literature now that are trying to find tools and surveys that can predict post-operative outcomes, and one of them is mental health and patient resilience, how much they catastrophize pain. I was wondering if there were any studies that have evaluated this relationship between patient expectations and their mental health, because I feel, and if whether or not they've compared, which is a stronger predictor of patient satisfaction and outcomes.
Yeah, there's definitely a lot of literature out there discussing sort of the patient qualities. I didn't really delve into it here, but there have been certain qualities about patients and how they're reporting on their preoperative surveys about mental health, about their psychological well-being, about their social support system, that all describe these patients that do either better or worse based off of these sort of more psychological sort of factors that impact patient care. I don't have the specific citations, but there's definitely a lot of literature out there right now about that.
And I think we have 2 questions on Zoom. Go to Dr. O'Neill next, and then Dr. Swaroop to follow.
Kaz, great talk. You touched on something earlier in your talk, talking about the sort of doctor-patient relationship. And I think one potential confounder of this expectations outcome relationship is the therapeutic alliance between doctor and patient, which, I think becomes more important the less, or I should say, the more tenuous the relationship between the pathology and the treatment. So it might not make a whole lot of difference for replacing arthritic hip, but it could make a big difference for, surgery for back pain, for example. And there are ways to measure that, believe it or not. They've basically been developed in the complementary medicine world. And I'm just wondering if you have thought at all about that as sort of a separate factor from expectations, or if you think that's something that's worth exploring in the context of orthopedics.
Oh, I think that's spot on. I think that's sort of one of the sort of magic juju as well, if you will, of this, where, so much of this is about how you as the physician are talking to your patient and the discussions that you're having. Because, your patient can come in with a certain set of expectations, and how you talk to them and what you talk to them about has an incredibly large impact on how they're going to feel about their surgery and the expectations that they have after talking to you. I think that therapeutic relationship is critical. And I think you bring up a good point as well, that this is actually all correlational work, right? So we're not saying the expectation is this, and therefore the outcome is this. We're just correlating these things. So I think there is a lot of room for confounders. And one of those is, the relationship between the physician and their patient, because that's something at least that I didn't talk about quantifying, but is something that can be quantified, as you brought up. Dr. Swarup, did you?
Hey guys. Fantastic summary. I know it's a really big area of research, and you summarized it really well in 45 minutes. So nice job, and congratulations on what you've been able to do. I'm obviously personally very proud of what you've been able to accomplish. My question for you is, we've talked about this a little bit, but now that, fast forwarding about 2 years since we started doing this, the whole relationship between outcomes and satisfaction, right, which you kind of alluded to at the end, how do you think we can bridge that gap, right? Outcomes as being something that's quantitative, that we as surgeons care a lot about, and then satisfaction being more qualitative. How do you think we can, better understand that relationship? Because that really seems to be what we need to do, right?
Yeah, I think it comes down to these sort of classes that I was discussing. The more that we can teach our patients and the more that we can talk to them about these things, we have 15 minutes in the clinical encounter to talk to our patients about this massive surgery that affects every minute of their life. We're sort of looking at this 15-minute piece of the pie of this patient, whereas the patient's living with this for every day, every minute of their life. And so the more that we can provide information to the patient, I think the better. So by teaching them and by giving them more information, we can both hopefully improve their satisfaction. And then, as was shown, if we can improve or change their expectations or try to make them expect that they're going to have a better outcome, potentially we can improve their outcomes as well. So I think it all comes down to the education component.
Thanks, Kaz. It was a really, really good summary. Really difficult and critical topic. I'm really glad you brought up the McNamara fallacy, because I think that's one of the biggest issues we have with these surveys, is that when someone says it's a validated survey, the validation is basically often bootstrapping, and so it really falls into the McNamara fallacy. And unfortunately, he also brought up sort of the nefarious side of this, which is now payers, including CMS, are going to use the tools that we've developed to try to figure out how to help patients in order to pay us less. Because make no mistake, that is exactly what CMS is doing, and private payers will follow suit. And that will decrease access, because people will essentially pick the patients who are going to do better in order to protect their financials. My question for you is really, how do you take sort of the challenges of this and really turn them around into making this better for patients? Is it patient education? Is it meeting expectations? Is it not operating on people who have the incorrect expectations? Sort of what would your one takeaway be about how do we sort of address the problem that these surveys kind of bring up?
Yeah, I feel like I'm a little bit of a broken record, but I do feel like it's through this education portion where I think that it's also such a minimal thing, like a 30-minute class is not that long to provide for a patient, and it's not something that we as the surgeons need to do. And the impact that it can have, and even the satisfaction work aside, even the outcomes, expectations work aside, I think that a patient, I can't see how a patient who's learning more about what they're going to be undergoing would be upset. So I feel like it's all benefit from the classes. And I think that that's sort of the key to it. I think there's a lot of variables, and, CMS changing how they're going to be paying surgeons for what they're doing based off of these various outcomes. Satisfaction is already so tied into how we're reimbursed, how the hospitals are rated. I didn't really go into this, but like Press Ganey and all these other things that I didn't even touch on in this talk, it's already something that's affecting how we're being compensated. So I think it's only more imperative that we as the surgeons take control to get better understanding of these topics so that we can be, in the driver's seat rather than the passenger seat.
Thanks, Kaz.